Good evening, friends, and welcome to this Tuesday academic session from the Department of Critical Care Medicine. And today we have Department of Hemato-Oncology. So we bring some interesting interactive topics of our clinical interest. So today we thought of bringing the thrombocytopenia in intensive care unit. It's an area of concerns in many of the times as a approach, evaluation, and also a management, and many times the controversies in and around the transfusion triggers. So to bring this topic, we have Dr. Shashidhar Pulgam, who is a senior consultant in the Department of Critical Care Medicine in Yashoda Hospitals, Secunderabad. So he will take us through the review of different aspects of thrombocytopenia in ICU and its prognostic value. And followed by, we have a seasoned speaker and a seasoned clinician as a senior fraternity from the Hemato-Oncology, Dr. Ganesh sir. Sir, we have an honor and privilege to have you here, sir. We welcome you.
Thank you, sir. Thank you so much. It's my honor and privilege to be amidst this virtual August platform, and I welcome all the delegates for this very important, interesting topic of thrombocytopenia in ICU. And I hope and I'm sure at the end of this discussion, everybody who is on this virtual platform will be benefited and will have many take-home messages from the discussion we will have. Thank you.
Yeah, sir. So over to you, Dr. Sasi, for your presentation.
Visiting as a Roman, we request all the visitors to kindly vacate the patient present. President BMT. Hospital visiting as I pray. Visitors, patient care and palliative system modeling. PDF-BMT. सभी विजिटर्स को सूचित किया जाता है कि विजिटिंग आज समाप्त हो गई है.
F5 प्रेस चाहिए सर.
आप पेशेंट की जगह को कार्य कर दें.
So reopen it again, sir.
Reopen. Is it visible now?
No, sir. Actually, I'm stopping it again. You try to reshare it.
Okay.
Reshare
it again. Open and reshare. Yes, yes, perfect. Please go ahead.
Good evening, everyone. Next 30 minutes, I will be talking about the thrombocytopenia in ICU. So to take us through this discussion, we have distinguished guest, Dr. Ganesh Jaishetwar, sir. He is Hemato-Oncologist from Yashoda Somajiguda. So coming to the discussion. It's not moving.
No, you try from the slides, from the down. In the left corner, there is a slight change.
So they use a keyboard.
Nothing is working actually.
Oh, no, sir. Just enter it again.
Reshare.
Just one moment. IT level error, sir. Okay, 2 minutes.
I think you can continue.
I'll do one thing. I'll share it 1 moment, sir. So once again, share it.
Okay.
Let's not delay, sir. I'll do one. I'm sharing it. Yes, sir. Good to start.
Yeah. So thrombocytopenia, it is a very common entity which we see in ICU. So there are two kinds of patient population. One is patient getting admitted to ICU with thrombocytopenia. Other is patient developing thrombocytopenia in ICU. So both the things we will discuss, but more or less more we will be interested in the patient developing thrombocytopenia in ICU. So normally, by definition, thrombocytopenia is platelet count of less than 150,000. So for mankind, there is a wide range of platelet normal value of platelets, that is 150 to 4 lakh, 1.5 lakh to 4 lakh per deciliter of the platelet count. And for a normal human being, the range is narrow. That means for a person, if the platelet count is 2 lakhs at this point of time, if you repeat it again in the next week or so, it will be in the same range. It won't be that much wide range of the platelet count. So if someone is having a platelet count drop by 50% all of a sudden, for any without any reason also, we need to evaluate for the thrombocytopenia. So basically, this platelet count is manipulated in the body by production from the marrow, and its platelets are pooled in the liver and spleen, where their elimination also occurs in the reticuloendothelial system. So production from the marrow and destruction or the destruction in the spleen that leads to the balance of the platelet count. So by definition, though it is less than 1.5 lakh, so usually it is considered as important when the platelet count is less than 1 lakh. So mild thrombocytopenia is considered as platelet count of less than 1.5 lakh. Moderate is in between 50 to 1 lakh, and severe when it is less than 50,000 of the platelet count. This definition also varies from the condition to condition. Suppose someone with ITP is there. Severe ITP we call when the platelet count is less than 30,000. That also varies. The normal definition is like this: 0 to 50, 50 to 1 lakh, 1 lakh to 1.5 lakh. So usually when someone develops thrombocytopenia in ICU, typically it will start after day 4, and it usually settles by day 10. So coming to the incidence, thrombocytopenia is a marker of prognostication also, that I will talk later. So coming to the incidence and prevalence, it is wide range, actually, depending on the ICU, whether it is adult ICU or pediatric ICU, whether it is medical ICU or surgical ICU, there is wide variation of the prevalence of the thrombocytopenia. Patients admitting to the medical ICU will have more patients will be admitted with thrombocytopenia in case of medical ICU, but patients developing thrombocytopenia in ICU, that we will see in more of surgical ICU. Usually post-surgical ICU, they are staying for longer period. They will have predominant thrombocytopenia, that too less than 1 lakh platelet count. So, next. So coming to the causes of thrombocytopenia, as we discussed, it is mainly either production problem or increased turnover or destruction. So this production problem is mainly from the marrow. It could be because of the bone marrow depression, could be because of any reasons, maybe drug-induced or immune-mediated or congenital, or infiltrative disorders, leukemia. So anything can cause the decreased production from the marrow, or increased turnover also because of the various reasons, either immune reasons or non-immune reasons. In the platelets, usually some 30% of platelets will be sequestrated into the spleen. So when there is a hypersplenism, like patients with the CLD, where there is a splenomegaly, or in any condition with splenomegaly, there will be some amount of thrombocytopenia because some pool of platelets will be sequestrated in the spleen. So when someone in the ICU requires invasive procedures, and they on life-sustaining devices like patient on ECMO, or patient requiring dialysis, patient on IABP support. So any mechanical supportive devices that lead to some amount of the damage of the platelets, that also causes thrombocytopenia in ICU. And coming to the trauma patients, are patients who are getting admitted with shock. So excessive administration of IV fluids or excessive administration of the blood and blood products, massive transfusion protocol, that lead to the hemodilution, which will lead to the thrombocytopenia. These are the various causes. Usually thrombocytopenia for one patient is not a single problem, it will be multifactorial problem. So what are the risk factors for development of the thrombocytopenia for ICU patients? Coming to the baseline factors, usually elderly people, female sex, patients with liver disorders, patients on immunosuppression like chemotherapy patients, and patients with high Apache score, high sickness at the time of ICU admission are the risk factors for developing the thrombocytopenia. And patients admitting with sepsis, trauma, DIC. So these conditions are prone to develop thrombocytopenia invariably. And other laboratory variables like patients admitting with low platelet count and patients having high lactate, high bilirubin, high creatinine, they are prone to develop thrombocytopenia in due course of the disease. And our intervention, as we discussed, someone with life-sustaining devices like extracorporeal membrane oxygenator or renal replacement therapy with dialysis and patients on mechanical ventilation, these conditions will lead to the drop in the platelet count. These are all various risk factors for development of the thrombocytopenia. Next slide. So why we will be worried about thrombocytopenia? Because it changes the outcomes. Thrombocytopenia per se won't cause the much problems, but won't cause much of the bleeding problems, but we will be worried about the bleeding always. So because there will be a bleeding risk, we will try to delay the invasive procedures like diagnostic procedures or therapeutic procedures if with fear of bleeding. And when someone requires anticoagulation, like patient on PTCA who requires anticoagulation with the fear of bleeding, we will stop the anticoagulation. That may lead to the stent thrombosis and that will lead to the problems. So, with the fear of bleeding, sometimes we will be giving the prophylactic platelet transfusions. So excessive administration of the blood and blood products. And because all these things get delayed and per se with thrombocytopenia, they may deteriorate further and we require the life-sustaining devices, and which will lead to the morbidity and increased mortality also. So that is the reason thrombocytopenia is very important for a patient in the ICU. If they are having thrombocytopenia, we have to address it immediately. What is the reason and all. So thrombocytopenia is a prognostic marker also. So coming to the various parameters in the platelet indices like mean platelet volume or mean platelet volume to the platelet count ratio and immature platelet fraction, all these things will give us when the marrow is going to improve or whether the patient is having sepsis or when the patient is going to improve. So these are the various platelet indices which will guide us the thing. And if we see any scoring systems, like SOFA, Apache, or MODES. So in any scoring system, platelet count is a marker. So that means any patient in ICU, if their platelet count is low, their outcomes will vary. So that is the reason platelet count is very important. So next, we will discuss the approach to thrombocytopenia with 4 or 5 cases. I have put 5 important cases here.
Yeah,
So,
Dr. Shashidhar, before we embark onto the cases, I'm sorry to interrupt, just for the, all the participants and August audience on this virtual platform. So the important take-home message till now is that thrombocytopenia is extremely common, more so in the hospitalized patients and amongst the hospitalized patients in the ICU. The incidence can be as high as 50%, varying degrees of thrombocytopenia if you go by the threshold of 150,000, the lowest limit of normal platelet count. So about 50% of these severe thrombocytopenia with the platelet count less than 50,000, the incidence is close to 15 to 20% across the critically ill patients admitted in the ICU. And the 2 commonest causes of thrombocytopenia in ICU, of course, the etiologies or the common causes may vary depending upon the kind of population you cater to across ICU, like, if it is a cardiac ICU, general ICU, or, organ specialty ICUs. But overall, in the general ICU, what we have seen is the 2 commonest causes of thrombocytopenia. One is sepsis and second is trauma. So polytrauma patients and severe sepsis patients, thrombocytopenia is relatively common. So let us embark on to these cases. So over to you, Dr. Shashidhar, please.
Yeah. Okay, sir. We'll go through the cases one by one, and all the participants, you can give your answers in the chat box. So what is your thought process, that also we'll see. So coming to the first case, this is a 67-year-old male patient admitted with the ACS. He received emergency PSA with implantation of several stents. One of them is in the LMCA, followed by therapeutic dose of anticoagulation with unfractionated heparin plus platelet inhibition with aspirin, cloplet, and eptifibatide. So after procedure, after 12 hours of the PTCA, CBP was repeated, which has shown sudden drop of platelets from 270, which is pre-procedure value, to 6,000. So and patient is looking clinically stable and he is not having any bleeding. So what is your thinking process? Next slide. So shall we stop the antiplatelet drugs, or shall we stop the heparin? Shall we give platelet transfusion, or shall we give Tranexa for this patient? What could be the cause of this low platelet count in this case? Here we can see the peripheral smear of the patient. So in the peripheral smear, there is clumping of the platelets. 2 areas you can see. Actually, I can't put the cursor. So in 2 areas you can see the clumping of the platelets. So what is the reason? Any answers? Platelet clumps are seen, but shall we address this issue or not?
I think in the chat box there are 2 answers: EDTA, platelet clumping, and platelet counts by Dr. Kavita, Dr. Srinivasu, and Dr. Debashish Ghosh, sir. So basically, Dr. Shashidhar, you have highlighted a very nice common case from our day-to-day clinical practice. So there is something, we call it as a houseman resident in a hurry or nurse in a hurry syndrome, right? So most of these critically ill sick patients, like this patient who has a recent cardiac intervention, and there is unexplained platelet drop without overt bleeding, right? And the first and foremost thing in such unexplained platelet drop is to check your peripheral smear. And many a times what happens, the residents or the nurses in the ICU, when they struggle, to collect the sample from these patients, they have multiple pokes to the patient, and then in a hurry, you try to collect the blood sample, and most of the times, because of this inappropriate collection of the blood sample, there is activation of primary hemostasis with platelet clumps. And that's a very, very common cause of what you call it as false or pseudo-thrombocytopenia. So whenever in doubt, in this case, absolutely successful cardiac intervention and unexplained sudden platelet drop without overt bleeding. And always check the, all the variables which can cause this falsely interpreted low platelet counts. And as you nicely elaborated, the peripheral smear showing platelet clumps. So probably the sample was collected not properly. There is activation of coagulation cascade. That is one possible explanation. Second is, some people are sensitive to EDTA-induced platelet agglutination aggregation. And when this happens, you end up with, the machine counts each small platelet of about 10 femtoliters as a platelet particle. So these clumps are counted either as a debris or a red blood cell or a white blood cell, because the platelet is the smallest of all the 3 blood cell lineages in the peripheral smear. So you will have a false low platelet count from the machine. So this is very important. So pseudo-thrombocytopenia as a cause of thrombocytopenia generated by the cell counter report should be avoided. And there are many explanations as nicely elaborated in the chat box. Dr. Mantena Maunika has iptafibatide induced pseudo-thrombocytopenia. So Dr. Sri Ganesh, pseudo-thrombocytopenia, all these answers are correct. So either EDTA induced platelet aggregation, or there are many drugs which can cause platelet aggregation, which can precipitate platelet aggregation, or a houseman or a nurse in a hurry circumstances which I elaborated. So this is one of the commonest and most important cause of falsely interpreted thrombocytopenia in the ICU, and we should have a thought process open for such possibility. Recheck the platelet count and ask the pathologist to have a look at the peripheral smear, particularly for platelet clumps. And whenever you have such suspicion of EDTA-induced platelet aggregation, you can collect the sample in alternative citrate vial, or you can check the peripheral smear directly, either directly or through the pathologist. Thank you, Dr. Shashidhar. Anybody has any comments or any doubts at this point of time can raise the hands so that we can discuss the important concerns, doubts, dilemmas pertinent to the case. Thank you, Dr. Shashidhar.
Yeah. Next slide. So as we discussed, this is pseudo-thrombocytopenia. Suppose if the drug given was abciximab, and if you couldn't see any platelet clumping in peripheral smear, maybe it is true thrombocytopenia. That we will come later. That could be because of drug-induced thrombocytopenia. So only abciximab can cause that immune-mediated thrombocytopenia within short span of the time. Next slide. Coming to the second case. Here we have a confused person, 64-year-old male, confused patient with history of multiple myeloma who has received a cycle of anti-neoplastic therapy, that is bortezomib plus dexamethasone the previous day, was admitted to ICU with fever, shivering and shock. So on examination, right lower limb was swollen and reddish. So his lab parameters have shown CRP of 247, procal 223 and creatinine of 2.2 with urea of 112. Coming to the coagulation parameters, INR is 1.7, APTT is 54 with a platelet count of 48,000. So what could be the possible cause of thrombocytopenia in this patient? This patient is a known multiple myeloma patient. He received chemotherapy one day before to the admission of the ICU. So he had, we found swelling on the right lower limb. Actually, picture was there that was missing here. So what could be the most probable cause of thrombocytopenia in this case? Whether it is, go back, chemotherapy related, sepsis related, or any other cause?
Yes, Bharti, you can ask your question.
Sepsis related. Majority, everyone is pointing towards sepsis. So
yes. There are two answers. Dr. Mona Lisa Sahu and another panelist has answered sepsis related. So let's move further, Dr. Shashidhar. So, I just wanted to highlight in a already an established hematological malignancy like myeloma. The patient is already on bortezomib-based chemotherapy protocol. Bortezomib per se, just like any other chemotherapy, has a more propensity to cause thrombocytopenia. That's a known factor. So in this case, this person has chemotherapy possibilities in this case can be either chemotherapy that is bortezomib related. He also has a sepsis, swollen hand with fever spikes. So sepsis is another added possibility. So clinically, these are the two, evident possibility in this case. So, and there are like the answers like Dr. Mona Lisa, Dr. Vignesh, sepsis related, Dr. Rajesh Kasi Mahanti, sepsis bortezomib related. That's absolutely all the answers proposed by the eminent panelists are correct. So over to you, Dr. Shashidhar.
yeah, it's multifactorial as we discussed. So chemotherapy can cause. if there is underlying malignancy related, he can have thrombocytopenia, and maybe that source of sepsis might got ignored before giving chemotherapy. After chemotherapy, that got flared up. That is the reason he got admitted with fever, shock, and cellulitis. So multifactorial thrombocytopenia in this case. Go to the next slide.
Yeah.
Next slide. So these are the various reasons how sepsis causes thrombocytopenia. Two important reasons are, one is hemophagocytosis with the sepsis, and other is development of TIC. So those two are the important things. Apart from that, multiple reasons to cause the thrombocytopenia in case of a sepsis patient. As we discussed earlier, sepsis is the predominant cause of thrombocytopenia in a medical ICU. Up to 75% of patients with sepsis will have thrombocytopenia in medical ICU. Okay, go to the next slide. Coming to the third case, this is 75-year-old female patient with stroke, right-sided hemiplegia, recurrent seizures, dysphagia, and aspiration pneumonia requiring invasive ventilation. She received several drugs, including antibiotics, sedation.
Dr. Shashidhar, before we go on to this case, like the previous case, there are some queries raised by our eminent panelists. Should I take them before?
Yes, sir.
So there is Dr. TG has raised a hand. So Doctor, I don't know the long form. Sorry. So you can please raise your question or doubt here. I had Dr. TG.
Dr.
You can
TG,
unmute
unmute
yourself.
and speak.
Dr. TG, you can unmute.
Ganesh sir, sometimes it may be by mistake also it may be raised. So
Okay. So Dr. Ravi R. Dr. Ravi R. I can see the hand raised.
So
Dr. Ravi.
we're given the access to them.
Okay.
They can speak actually, they can unmute and speak.
Okay. So let's move ahead. So if there are further concerns, we can address at the end of this.
Next case, that is a stroke patient with seizures and aspiration pneumonia and ventilation, received several drugs, including antibiotics, sedation, aspirin, unfractionated heparin prophylactic dose, diuretics, and anticonvulsants. On day 7, valproate was added to the levetiracetam and lorazepam to control the seizures, because she was throwing continuous seizures. We added the second drug on day 7. After adding that, after 10 days, the platelet count began to fall, reaching to a value of 50,000. Next slide. So what is the cause of thrombocytopenia in this case? Whether sepsis related, drug related, or because the patient is on heparin, is it a hit? So majority are answering hit. There are 1-2 people who have answered it as
So the answers Dr. Vignesh has given as a drug. Another eminent attendee has answered hit. Dr. Isha Hospital hit. Dr. Jashwantini hit. Dr. Manthena both hit and drug induced. Dr. Rajesh valproate and Dr. Sri Ganesh hit. So Dr. Shashidhar, over to you.
Yeah. So drug related, it could be anything actually, but because we started valproate on day 7, and after starting of valproate, there is a time lag of almost 10 days. So after 10th day of valproate initiation, this thrombocytopenia has started. That is the reason. Most probably it might be because of valproate related, drug related. Why not hit in this case? Usually hit will present in the 5th to 10th day. So once we initiate the heparin, so after the initiation of the heparin, from 5th to 10th day, usually we will see the heparin-induced thrombocytopenia. So sepsis related, obviously patient is stable, and maybe by that time they might have done tracheostomy and weaned also. So that is the reason sepsis is a lowest possibility. It could be anything, but drug related comes as a first priority in this case.
Yes, Dr. Shashidhar. So as you highlighted, HIT, sepsis drug, all are possibilities. For HIT, there is a very nice ready to calculate pre-test probability score, that is 40 score for HIT, and I'm sure based on the patient's clinical presentation, the HIT pre-test probability will be very low. How do we manage or decide on HIT? Because HIT is kind of medical emergency. In such patients who are on heparin based anticoagulation, you need to switch over to alternate anticoagulation. That's life-saving. This is done for those who have a pre-test probability score which comes into the high probability score. You have to change heparin to alternative anticoagulation. So the factors in this pre-test probability are 4T, the timing of thrombocytopenia, presence of any thrombosis, skin reaction, and any anaphylactic reaction. So based on this, there is a very nice, readily available app-based score. So those persons who have a low pre-test probability score, we tend to, still send the, very low pre-test probability score. You can skip, but intermediate score, we do this HIT antibody, that is anti-PF4 platelet factor 4 HIT IgG ELISA antibody, and if it is positive, you tend to alternate the anticoagulation with the suitable non-heparin anticoagulants. Those with high pretest probability, you just stop heparin and change to alternative anticoagulation, monitor them closely, because mortality can be very high because of disseminated coagulation in activation in these patients. Second, with regard to drug-related thrombocytopenia, normally the onset is, of course, it can be idiosyncratic drug reaction or dose-dependent drug-related thrombocytopenia. So normal, the temporal onset of thrombocytopenia, like 7 to 14 days after starting the drug, you suspect, and and the nadir is achieved within 3 to 4 days of initiation of thrombocytopenia. And once you stop the drug, the platelet count doesn't bounce back to normal immediately. Sometimes it can take up to 7 days. So that is very important to understand and remember, because many a times once we stop the drug, and if the platelets are not recovering, we tend to, consider alternative diagnosis with aggressive other interventions, which can, complicate the case scenario. The second important thing is, sepsis related and drug related thrombocytopenia. Whatever the etiology of thrombocytopenia in the ICU, unless patient is actively bleeding or you are not anticipating any invasive procedure, platelet transfusions can be withheld safely. So the evidence for aggressive prophylactic platelet transfusion in non-bleeding patients or patients not anticipated for planned for any invasive procedure is very weak, and it can be counterproductive. So the threshold for platelet transfusion in such sick patients is platelet count below 10,000. Barring this, fever, active bleeding, active coagulopathy, or anticipated procedure, these are the circumstances where up to platelet count of 50,000 platelet transfusions are justified. It's very important. The absolute threshold for platelet transfusion is platelet count 10,000 or below. For patients with coagulopathy, fever, 20,000-30,000 is also important. And for procedures like, normal minor procedure like central venous line insertion, platelet count of 50,000, major surgery 50,000. Barring ophthalmic surgery, brain surgery, brain trauma, or brain bleeding patients, or patients with anticipated lumbar puncture, where platelet count of 70,000 is mandatory. For ophthalmic CNS surgery, platelet count of 1 lakh is mandatory. So I think that was important to understand. So another attendee has raised a question: is antibody testing is not mandatory for diagnosis of HIT? That's the question. So antibody testing is not mandatory for the diagnosis of HIT. As such, the pretest probability score, high score are considered, 40 score, those belonging to high score, they have HIT. Antibody testing is helpful in patients with intermediate HIT score. I guess and hope that this answers the query. So over to you, Dr. Shashidhar.
Next slide. So drug-induced thrombocytopenia, the mechanism of drug-induced thrombocytopenia is direct toxicity by the drug, or drug causing the bone marrow suppression, or immune-mediated destruction. These are the three types of mechanisms by which drugs can cause thrombocytopenia. Heparin is also a drug. So all the drugs causes thrombocytopenia that will be pro-hemorrhagic. Only heparin is thrombocytopenia where it is a pro-thrombotic state. Next slide. So these are the various mechanisms. Skip it. Next. Next slide. So the list of drugs, any type of drug can cause thrombocytopenia. If you see the list, it is a vast list. Next slide. So HIT scoring, HIT probability scoring, that is 40 score. Here we have 4 parameters and with 2 points for each parameter. So if your score is coming to high probability, that is 6 to 8, then HIT is likely. If the score is low, then less likely. So 40 score is having more negative predictive value than positive predictive value. So if your 40 score is very low, then you can rule out the HIT in the patient. If 40 score is high, then we have to evaluate for the HIT. And if there is thrombosis with thrombocytopenia, definitely you have to involve the hematologist for the further diagnosis and treatment of the patient. And as we discussed, anticoagulant plan has to be changed. From heparin, we have to change to either fondaparinux or direct thrombin inhibitors. Next slide. So this is the temporal association. After exposure of the HIT, usually thrombocytopenia starts after day 4. So majority of the times we will see the HIT in the first 5 to 10 days. So that is the duration where we will see the HIT. So if the patient is having previous exposure of the heparin, even HIT can be presented in the first day, second day of the exposure to the heparin. Next slide. Next. So we'll go to the next case. So this is an interesting case actually. 40-year-old female, known hypertensive, diabetic. She presented with severe upper abdominal pain, vomiting, and burning micturition. There is no history of fever, loose stools, or blunt trauma to the abdomen. So basically, she came with abdominal pain, vomiting, and burning micturition. She was febrile in the ER. Though she is not giving history of fever, she was febrile with 1 or 2 temperature with stable hemodynamics in ER. And on systemic examination was unremarkable except for the diffuse tenderness in the abdomen. Next slide. Her initial laboratory parameters are almost nearer to the normal, though not normal, nearer to the normal. HB is 10.5 and a platelet count of 1,94,000. And creatinine is slightly elevated with 1.7. Amylase, lipase are normal. Albumin is normal. Calcium is normal. Ultrasound of abdomen is done. That is normal. Her lipid profile, urine examination were unremarkable. And she was started on antibiotic thinking that it is urosepsis and started on IV fluids. So next slide. After 2 days, she deteriorated. She developed jaundice, became oliguric, and started to have spontaneous bruises and hematuria. When we repeated the labs, there is an abrupt drop of hemoglobin from 10.5 to 7.2, and the platelet count dropped from 1,94,000 to 42,000. There is a rise in the serum creatinine from 1.7 to 2.7. Bilirubin is 3.2 with the direct of 1.2 and mild elevation in the AST and ALT values. When we repeated the LDH is sky high, that is 4,288. Her PT, APTT, D-dimer, fibrinogen levels were normal. Her peripheral blood picture has shown numerous fragmented RBCs with cystocytes. Coombs test and vasculitis workup were done. They are negative, and her complement levels were within the normal limit. what is the possible cause of thrombocytopenia and worsening of the condition for this lady. Admitted in a normal sensorium, then she developed jaundice, oliguria, worsening renal parameters, drop in the hemoglobin with drop in platelet count, with the raised bilirubin. In that they have given direct of 1.2, indirect is 2.1 with raised LDH. Peripheral smear showing fragmented RBCs with cystocytes.
So it was a very nice case, Dr. Shashidhar. So the answers are Dr. Rajesh Kasimanti, HUS, Rakesh Kurandwad, HUS, Isha Hospital, HUS, Mantena Monica, HUS, TTP, Dr. Jashwantini Maha, cause of drop in HB and platelet, Galaxy Mobile, HUS, Dr. Vignesh, microangiopathic hemolytic anemia. One attendee has written splenomegaly, Dr. Rajesh Kashimanti, HUS, etiology unclear. Was Dr. Vasundhara, obstructive biliary sepsis leading to acute pancreatitis, and Dr. Mona Lisa Sahu, HUS, Dr. Sri Ganesh, thrombotic microangiopathy. So essentially, this is an interesting case, and it's kind of common in the ICU practice. So this lady, middle-aged lady or young lady who has abdominal pain, fever, UTI, rapid worsening next few days with oliguric AKI, hemolytic anemia because unconjugated hyperbilirubinemia with significant HB drop, thrombocytopenia, and LDH being extremely high. So this is like she has evidence of microangiopathic hemolytic anemia, progressive thrombocytopenia, and also AKI. So this, and with very high LDH. So definitely, and the peripheral smear is showing fragmented RBCs, schistocytes. So this is a case of microangiopathic hemolytic anemia, thrombocytopenia, AKI, goes into the triad of TTP. So again, those who have raised the possibility of HUS because of the clinical presentation of this lady with abdominal pain and vomiting initially, that is also a possible. Again, in the thrombotic microangiopathy spectrum, these are all the possibilities. But HUS, again, hematuria and abdominal pain and plus doubtful diarrhea, that is also justified. But essentially, this lady has microangiopathic hemolytic anemia with AKI, so with thrombocytopenia. So all these possibilities are correct. I think there are many more who have. So, and somebody has written malaria. So what is your take on that, Dr. Shashidhar?
Yeah, same thing, sir. Thrombotic microangiopathy, basically, microangiopathic hemolytic anemia. So HUS and TTP are the possibilities here. And it is fitting into the classical thing.
Yes. So basically, most important thing for all the eminent attendees, I will like to enumerate here. TTP, thrombotic thrombocytopenic purpura, one of the common causes of thrombotic microangiopathy. The classical pentad, as described in Harrison's, is seen in less than 10% of the patients, number one. All these 5 parameters or 5 essential pentad characteristics of TTPs are hardly seen in clinical practice. So any 2-3 inappropriate clinical circumstances should raise the suspicion of thrombotic microangiopathy like TTP, HUS, and the patient should be managed accordingly because this is medical emergency and the gold standard plasma exchange, if not started within time, the mortality can be very, very high. That is one. Second, for all the attendees, again, cystocytes. Again, classical cystocytes can be missed many a time. So any significant RBC abnormality like microspherocytes, cystocytes, broken RBCs, RBCs with sharp margins and all these characteristics, more than 1% on the peripheral smear. So more than 1% is not 1 per high microscopic field, but more than 1% of the RBC population in the appropriate clinical circumstances and lab parameters is justified to be considered as thrombotic microangiopathy and justified to be initiated on the gold standard plasma exchange in such patients. So this is a classical illustration of TTP. Again, many a times we miss thrombotic microangiopathies more so in the ICU setting if we insist on the select parameters. Clinical picture in coordination or in addition to the prerequisite suggestive supportive lab parameters should raise the concern or the diagnostic possibility of TTP. So we have one of the eminent clinicians from our own region who presented with isolated thrombocytopenia in the ICU. Unfortunately, the picture was subtle. She has subtle neurological changes. Next day morning, she has seizures. And before the diagnosis could be rethink of other alternative diagnosis, she succumbed and it was a missed case of TTP. So TTP can be, these thrombotic microangiopathies can have very, very stormy course, and the case fatality rate can be very high. If your clinical suspicion, you should have a high index of suspicion under these clinical circumstances with appropriate lab parameters. So again, HUS, TTP, all these are the spectrum of thrombotic microangiopathy. Based on the clinical parameters and the lab parameters, for HUS, you need to have the evidence of coagulation, the complement cascade activation along with the appropriate clinical history, either classical HUS or atypical HUS. Most important is, as I mentioned earlier, patients without active overt bleeding and patients not contemplated for any invasive procedure, platelet transfusions can be detrimental in thrombotic microangiopathies like this case. Many times you have patients with platelet count 10,000 also, but if there is no active bleeding, platelet transfusion should be avoided. So platelet transfusion contraindications are thrombotic microangiopathy, heat, and a relative contraindication is ITP unless and until the patient has active bleeding. This platelet transfusion doesn't work in ITP, and platelet transfusions can be clinically detrimental in the thrombotic microangiopathies. So over to you, Dr. Shashidhar. Let us, anybody has any other concerns or doubts, please raise your questions through the chat box, and you can even raise your hand and you can be on live to discuss your doubts. Thank you. Over to you, Dr. Shashidhar.
Yeah, this is a case of TTP. So as sir discussed, if we don't initiate the plasma pheresis immediately, then mortality will be up to 80 to 90%. So missing a diagnosis of TTP is, we have to pay a lot. So next slide. And this is the pentad. So pentad won't be seen. We discussed everything in detail. Next. So coming to the fourth case. So 32-year-old female with fever, altered sensorium, admitted to the ICU. Initial labs have shown hemoglobin of 9.2, white cell count of 13,000, platelet count of 42,000. Creatinine of 2.1, normal LFT with normal PT-APDT values, and LDH is 325. CUE is normal, no bleeding manifestations. Next. So tropical workup was done, malaria, dengue, lepto, scrub, everything was ruled out. Ultrasound wise also there is no organomegaly. Started on fluids, and still there is a suspicion of tropical fever. Started on ceftriaxone and doxycycline. As patient was not responding and continued to be altered in sensorium, planned for LPCSF after MRI brain. So then because platelets were persistently on the lower side, that is somewhere around 30,000, LP was done after a transfusion of SDP. The CSF meningitis panel has shown HSV PCR positive, started on acyclovir. Next, patient has improved. Next slide. Patient sensorium has improved and she became febrile after 5 days. Everything got normalized except platelet count. Platelet count remained at 40,000. So what is the possible reason for the persistent low platelet count, and what is the plan of evaluation? So tropical were ruled out, and it is a clear-cut case of viral encephalitis. So improved with acyclovir, but platelet count from admission, it was on the lower side. In between, it has dropped further, but remained at 40,000. Ultrasound, someone asked, it is normal. There is no splenomegaly.
Anybody has any further answers on the, so I can see a lot of answers coming up. Dr. Kavita, I will answer Dr. Kavita's question after this case. Dr. Rajesh, no splenomegaly on USG abdomen. Nithilan Bharti peripheral smear picture. Dr. Shashidhar, peripheral smear picture. Very important question. So the peripheral smear showed isolated thrombocytopenia without any change in red blood cells or in the WBC count, and differential was normal. Dr. Jashwantini, secondary ITP, Dr. Sri Ganesh, ITP, Dr. Manthana, underlying ITP, Dr. Vignesh, ITP, if everything is ruled out. So I'm sure, all the answers are correct here. It, in a patient who has viral encephalitis or any viral prodrome, persistent thrombocytopenia, isolated thrombocytopenia without any other abnormalities on the peripheral smear, the clinical suspicion is ITP. And what is the gold standard of ITP diagnosis? The gold standard of ITP diagnosis is the treatment response to ITP directed therapy, and the first line gold standard of ITP directed therapy is steroids, right? So once this patient is started on steroids, the platelet count improvement in a span of 7 to 14 days is consistent with the diagnosis of ITP. Sometimes the platelet count can recover early within 3 to 4 days, but the normal time of onset of steroids in ITP patients is 7 to 14 days. So, so the diagnosis, so any viral prodrome, here it is viral meningoencephalitis, but any viral prodrome which can be clinically evident, sometimes it is just common cold, and after cold, the platelet starts dropping, and not necessarily all the patients will have bleeding manifestations. So isolated thrombocytopenia. So basically, clinically, ITP is a diagnosis of exclusion, right? So you have any other alternative of thrombocytopenia possibility, that diagnosis needs to be considered and ruled out. So isolated thrombocytopenia and platelet response to ITP directed therapy like steroids is consistent with the diagnosis of ITP. Dr. Rajesh Kasi Mahanti asked, do we need to do bone marrow for diagnosis of ITP? Absolutely not. Bone marrow is not mandatory for diagnosis of ITP, but if you have a clinical dilemma of other possibility of thrombocytopenia, which involves hematological diseases, under appropriate clinical circumstances, you can do the bone marrow to rule out other possibilities, right? ITP is peripheral destruction of platelet because of antiplatelet antibodies. And those who have viral prodrome, these viral antiviral antibodies may cross-react with platelets and can cause thrombocytopenia, and that is ITP. So bone marrow examination is not mandatory for the diagnosis of ITP. But yes, if there is a very, both extremes of ages, very young children or elderly people, where other thrombocytopenia etiologies are common in elderly patients, hematological etiologies like MDS, malignancies, we can do bone marrow if the clinical suspicion is supportive. In younger children below 10 years of age, the inherited marrow failure syndromes can present with isolated thrombocytopenia. And if these children have, features suggestive of such hematological abnormalities like dysmorphic faces, history of thrombocytopenia in families, or persistent thrombocytopenia for a longer period of time, you can do bone marrow to clear these etiologies. Dr. Mona Lisa Sahu has recommended IVIG in ITP. So this particular patient who has viral meningoencephalitis, platelet count is 40,000, right? So the hemostatically safe target platelet count in patients with ITP is 30,000. So if the patient's platelet count is above 30,000, the patients have a very, very minimal chance of catastrophic, serious, life-threatening internal bleed like intracranial, intra-abdominal bleed, right? So the goal, therapeutic goal of management in ITP is to prevent serious internal bleed. And for that, you need to maintain a platelet count of at least 30,000. IVIG is one of the most rapidly acting drug in ITP. As I mentioned, the steroid action can happen between 7 to 14 days. So patient is stable, no active bleeding, and platelet count is above 20,000. You don't need to rush to other therapies. But if the patient's platelet count is less than 10,000, patient is actively bleeding, elderly patients with uncontrolled hypertension where chances of intracranial bleed are high, these are the circumstances, or patient in whom you are suspecting ongoing internal bleed like ongoing GI bleed with rapid drop in hemoglobin, possible intracranial bleed. There you use IVIG, because with IVIG platelet counts can start recovering within 24 to 48 hours. In patients with serious ongoing bleed or possible internal bleed, you can give IVIG, and after IVIG you can transfuse platelets so that IVIG will block the antiplatelet antibodies, and after that the platelet count with platelet transfusion will increase. I hope that answers Dr. Mona Lisa Madam's question, the doubts. Should we give rituximab in ITP? Dr. J. Sahu. Rituximab is the slowest acting agent in ITP. In adults, about 30% ITPs are self-limiting. That means the patient's recovers platelet count over a period of time with or without treatment. So rituximab is given only for patients with chronic ITP with recurrent waxing waning platelet count, and the onset of action of rituximab is 1 to 3 months, and about 60 to 70% patients with chronic ITP maintain platelet count with rituximab directed therapy. Dr. Rajesh Kashimanti says, sorry for the late response. Do we need to do bone marrow examination in elderly to rule out MDS in case of isolated thrombocytopenia? If there is a persistent thrombocytopenia in elderly patients, or these elderly patients have repeated bleeding episodes, you can do bone marrow to rule out MDS versus ITP. That is true. That you can do. But isolated thrombocytopenia, you give them a trial of steroids and see if the platelet count improves with the steroids. And if the platelet count doesn't improve with steroids, then you can do the bone marrow to rule out other possibilities of thrombocytopenia. Now, Dr. Jyoti want to know the cutoff for platelet count for eye surgery like cataract and retina surgeries where block is given. In cataract cases done without blocks. That's a very important question. Thank you so much, Dr. Jyoti, for bringing out this question on this board. So yes, for major ophthalmic surgeries, platelet count of 1 lakh is mandatory, because any slightest of bleed there can cause very debilitating visual abnormalities. So platelet count of 1 lakh for major eye surgeries are mandatory. Cataract surgery is different. So most of the times cataract surgery is a bloodless surgery. So there is a dilemma, but still, in the event of these patients require further extension of surgery for any complications, we will recommend to keep a platelet count of 1 lakh even in cataract surgery patients. Practically, theoretically, because it is a bloodless surgery, platelet count of 50,000 can be considered appropriate if the patient is absolutely without any comorbidities and it's a easily doable surgery. But if in event of any complication, when you need extensive eye surgery or redo surgery, in those cases, platelet count of 1 lakh is mandatory. So, and then there was one question by Dr. Kavita, difference between HUS, TTP. Both are the spectrum of thrombotic microangiopathies. So both present similarly, as I mentioned earlier, the classical pentad is not required for the diagnosis of TTP. In classical HUS, history of gastroenteritis and the documentation of STEC is supportive for the diagnosis of HUS. Atypical HUS, where there are various abnormalities of complement activation and regulation, those needs extensive diagnostic workup with those mutations and those complement activation markers. But practically, it is difficult many a times to differentiate between HUS and the TTP without the classical pentad. But the treatment under these circumstances, those without the antecedent gastroenteritis or documentation of this infection, we consider TTP and start them on therapeutic plasma exchange. So indication of using L-Thrombopag in thrombocytopenia, another question by Dr. Rajesh Kashi Mahanti. So L-Thrombopag and Romiplostim are thrombopoietin receptor agonists used for ITP, mostly the persistent ITP, like acute persistent ITP when the diagnosis of ITP is between 3 to 6 months, or chronic ITP when the ITP is existing for more than 6 months. Many times we use these drugs upfront also if the patient has severe thrombocytopenia, or patient has active ongoing bleed, or the patient has like children with possible ongoing internal bleed, because these drugs increases the platelet count in a span of about 1 week and are supportive to steroids at diagnosis, particularly when the patients can't afford the costly IVIG in those dire circumstances. Normally, L-Thrombopag and Romiplostim are used for chronic ITP as a steroid sparing agent to maintain the platelet count without long-term steroid toxicity. So recommended steroid for ITP, and when don't you off and how for long. So the steroid normally we use, you can use pulse steroids, or you can use the normal oral prednisolone 1 milligram per kg. If the patient has severe thrombocytopenia, ongoing bleed, we use pulse steroids, but barring that, non-bleeding patients, we use oral prednisone at 1 milligram per kg. Thank you, Dr. Shashidhar. That was long, so let us proceed with your cases.
Coming to the last case, sir, we had elaborate discussion on ITP so far. This is a 18-year-old female met with RTA. She presented to ER with GCS of 6. On presentation, she was in shock, so intubated, resuscitated, and after optimization of her hemodynamic, shifted for CT polytrauma. And then after CT polytrauma, she was transferred to the ICU. Her initial labs in the ICU were hemoglobin of 6 with platelet count of 2,99,000 and INR of 1.3 with the APTT of 48. CT polytrauma has shown bilateral SAH with frontal contusions, facial bone fractures, pelvic bone fracture with retroperitoneal hematoma and contrast leak. Next slide. So looking at the labs, massive transfusion protocol was alerted and continued with the blood and blood products transfusion. After 6 hours, again labs were repeated, which have shown hemoglobin of 9 and platelet count of 51,000. So what is the cause of thrombocytopenia in this case?
So I can see 2 questions. Dr. Rajesh Kashimanti, dilution. Dr. Mantena Monica, dilutional thrombocytopenia. Dr. Monica Sahu, madam, hemodilution. Dr. Isha Hospital, dilutional and blood loss associated. Kavita Chandri Kumar, consumption coagulopathy. Sri Ganesh. Dr. Vignesh, dilutional versus consumption. Dr. Sri Ganesh, DIC. I think all these answers are perfect explanations of thrombocytopenia in this case. This patient has polytrauma with ongoing intra-abdominal bleed. So this can lead to such massive transfusion protocol has been initiated. The blood loss is more than 2 liters because I think there is a significant HB drop, and there are hemoperitoneum with pelvic bone fracture. So polytrauma patient presenting with such thrombocytopenia on a massive transfusion protocol, the possibilities of thrombocytopenia can be many or multifactorial. The commonest one is polytrauma associated coagulation activation leading to consumptive coagulopathy and platelets being consumed in this primary as well as secondary hemostasis thrombocytopenia. Because the patient is started on massive transfusion protocol, even though the patient can have dilutional thrombocytopenia, and ultimately these polytrauma patients they end up with DIC. So DIC, because the APTT I can see was very high. So again, the patient has already evidence of ongoing DIC. So consumptive coagulopathy like DIC, hemodilution, and ongoing blood loss, in intra-abdominal blood loss. All these are possible rationales for thrombocytopenia in this patient. The plan of management, already patient has been started on massive transfusion protocol, which includes packed RBCs, FFPs, and platelets 1:1:1 transfusion till we achieve the optimal hemostatically safe hemoglobin and platelet count along with the coagulation parameters within 1.5 times normal. So Dr. Shashidhar, over to you again.
Yeah, next slide. So with this background knowledge, algorithm approach to thrombocytopenia. So first is see the peripheral smear, whether it is true thrombocytopenia or fast thrombocytopenia. If there is sudden drop in the hemoglobin from 2 lakhs to single digit, then most probably that might be the wrong sample. So repeat the sample by sending in either citrate or heparinized sample. And when you see a patient with thrombocytopenia, first thing is whether that is an emergency or not. So you see whether the patient is bleeding or patient is not bleeding. If patient is not bleeding, you have time for evaluation. And with your DDs in place, you try to have a goal of more than 50,000 platelet count in a bleeding patient. If patient is not bleeding, patient is stable, then look into the possibilities. So here you review the history of the patient, since how long he is having thrombocytopenia, are there any medical records before? So whether the patient is having thrombocytopenia from before or it is a new onset thrombocytopenia, and look into the other cell lineages, whether there is only isolated thrombocytopenia or there is a change in the hemoglobin and even white cell count also. If there are association with the other cell lines, then it could be because of the GI bleed or it could be because of the marrow problem. And if there is no association, or if there is association and if you anticipate that there is abnormal cells in the peripheral sphere, like cystocytes, then you suspect TMA. And once you are suspecting TMA, you do the required analysis by sending the Adam TS13 level to rule out the TTP. And when you are suspecting the drug history, look back the charts of the patient. Any drug was started 5 to 7 days before, or some drugs like Abciximab, which we discussed, can cause thrombocytopenia immediately also. So whether any new drug has started or any drug has started after starting the drug, if platelet drop is there after 5 to 7 days, then that could be the culprit. And look for the sepsis component in the ICU patients. So majority of the ICU patients, as we discussed, sepsis is an underlying contributor of thrombocytopenia. And in case of massive blood transfusions or massive IV fluid administration, dilution can be the possibility. And if the patient is on artificial life-sustaining devices like ECMO or RRT, and a patient on IABP. Maybe mechanical devices might have destroyed the platelets. That might be the cause for the thrombocytopenia. Next slide. So with that flow chart, same thing, look into the history, examine the patient. Are there any petechiae, purpura or ecchymosis on the skin? Or any if purpura is there, whether it is dry purpura or wet purpura. Wet purpura is again dangerous because that is a sign of bleeding. So you have to start platelet administration immediately. And once you see the patient, look into the peripheral smear and other cell lines. So if there is isolated thrombocytopenia, look into the HIV and HCV testing along with the other viral testing also. And if you are suspecting different causes, involve the hematologist and do ANA profile, APLA, liver profile. And when you are suspecting HIT and TMA, definitely you have to involve the hematologist. Next slide. So these are various clues, again, same repetition. Next slide. We'll go into the transfusion thresholds. So briefly, next slide. So predicting the risk of bleeding with a patient in ICU with thrombocytopenia, it is very difficult. Neither TEGR nor bleeding time or any other bleeding parameter has not shown any valid risk that this patient is going to bleed. So there is the absolute value of platelet count is also not much important when it is more than 50,000. So critical value was considered previously 40,000. And if you have a patient with the previous platelet count of 40,000, that previous admission at 40,000, if patient has bleeding, then most probably in this admission also, if his platelet count is same like 40,000, he may bleed. That is one of the marker or predictor. Or if the patient is having ongoing fever, infection, and any inflammatory ongoing inflammatory process, then that can tell that there is a high risk for bleeding. So the reason for thrombocytopenia, like patient with immune-mediated thrombocytopenia, they are having low risk for bleeding compared to the other thrombocytopenic patients. And patients with mucosal bleeding, patient having wet purpura, like gum bleeding or hematuria. So hematuria is the first thing which will predict that the patient is going to have a significant bleeding. So these are the various clues which will tell us that this patient is going to have bleeding with the thrombocytopenia. So with this background, patient without any bleeding, the platelet count of 10,000 is taken as normal. Someone with less than 10,000, then we have to transfuse the platelets. Or previous slide. So if you are going for previous slide, if you are going for any invasive procedure or line insertion, so there are various guidelines. I have gone through all the guidelines, but which we follow, that I have put here. So for any invasive procedure or line insertion, so we will take 50,000 as cutoff. And as we discussed, any neurosurgical procedure or ocular procedure, 1 lakh as cutoff. And for lumbar puncture, other biopsies, everything, any invasive procedure, 50,000. And for spinal anesthesia, it is 50,000. For epidural anesthesia, it is 80,000. But as per the up to date, you can do the central line even at 10,000 with careful observation, and if it is a compressible site. Or normally, if someone's platelet count is more than 20,000, you can do LP, you can do the central line insertion or arterial line insertion. And for a patient with hematological malignancy, 20,000 can be taken as cutoff for the lumbar puncture, or for a normal person, 40,000 as a cutoff. And someone bleeding, then only you have to administer the platelets if it is less than 50,000. So these are the various transfusion triggers in the ICU. Ganesh sir.
Thank you, Sasi. I think both of you tried to cover all the questions, cases, and interacted with the participants in a very organized manner. So it's actually covered most of it. Sir, will we take some more questions, or it's a time to call off?
No, that we can take, but I think we should, it's first of all, Dr. Venkat Ramana sir, Dr. Shashidhar, congratulations for bringing out such an important topic in such an illustrative, understandable way. And I'm really thankful and overwhelmed by the number of participants on this virtual platform. We have close to 175 participants for this webinar. So, thank you one and all for sparing time amidst busy schedule on a weekday. And, it was really wonderful. And I hope.
Dr. Ganesh sir, can we actually take us a few more questions? Like we most of the time see a viral phenomenon in many of these tropical situations, including either you say arboviruses or many similar kind of viruses where you see leukopenia followed by thrombocytopenia.
Yes.
And my questions will not be related to that, but what happens is sometimes 90% of the times this viral thrombocytopenia gets recovered in end of the first week to second week, which is common trend which we see. But in situations where it gets delayed and goes beyond few weeks, so there are some concerns, queries raised at that time. I just said the ITP earlier, which we used to call it a idiopathic thrombocytopenia. Now we are calling it immune-mediated thrombocytopenia, can also triggered by some of these viral syndromes. And there were some concerns, there were some queries raised when this situation comes, the role of corticosteroids or any form of steroids. What is your take? I will come to that because we will avoid those controversies of using steroids in a typical viral phenomenon which has no scientific basis in them, because most of them have a spontaneous recovery.
Correct.
But when it gets delayed and you have a suspicion of ITP, how do you take?
So what we do, like for appropriate clinical circumstances, a viral prodrome followed by persistent thrombocytopenia, then it is appropriate to consider the clinical possibility of ITP. Again, not all patients of ITP, you need to jump on to ITP-directed therapy, and that's the gold standard initial therapy, steroids. So unless and until patient's platelet count is less than 20, 30,000, or the patient has active bleeding, we don't start steroids. You can have a watchful waiting, see the tempo of this tempo and severity of thrombocytopenia over a period of time. Patient has persistent severe thrombocytopenia, patient has recurrent mucocutaneous bleed or any mucocutaneous bleed, you can start
duration, sir. Duration.
And duration, normally there are like
the cutoff duration where you consider steroids.
Yes. So persistent thrombocytopenia beyond 14 days, persistent severe thrombocytopenia beyond 14 days is the time when we consider, because this infection-associated thrombocytopenia can also be a possibility in those patients. So if the thrombocytopenia persists beyond 2 weeks and the patient has no other possible causes of thrombocytopenia, you can consider ITP, and the ITP-directed therapy with steroid should be initiated only if the patient has any mucocutaneous bleed or if the patient's platelet count is less than 30,000.
Which steroid? What is the dose? We have been seeing that controversy of methylprednisolone compared to dexamethasone.
Correct. So there is a lot of dilemma with regard to the type of the steroids. Essentially, all the steroids, whether you give pulse steroids or conventional prednisolone 1 milligram per kg, pulse steroids with dexamethasone or methylprednisolone, the response rates are more or less same. Adding pulse high dose steroids doesn't increase the response rate or doesn't fasten the platelet recovery in this patient. The time to response is same 7 to 14 days. Depending upon the clinical circumstances, if the patient has severe thrombocytopenia, patient has ongoing active bleed, you can consider adding pulse steroids. But barring that, adding oral prednisolone 1 milligram per kg is sufficient in these patients. Duration of steroids, the new American Society of Hematology guidelines mentioned to limit the exposure to steroid as less as possible. You give the full dose steroids for 2 weeks, see the response, and if your hemostatically safe target platelet count of 30,000 is achieved, you try to rapidly taper off the steroids and maintain the patient on the lowest possible dose of steroids to maintain the hemostatically safe target platelet count of 30,000, nearby 30,000. That's the main goal of therapy in these patients. If patient has rebound thrombocytopenia on steroid taper, do the extensive ITP, secondary ITP workup, autoimmune profile. If the patient has secondary ITP, underlying any autoimmune disorders, add steroid sparing immunosuppressants, or nowadays for patients with recurrent rebound thrombocytopenia on steroid taper, you can add thrombopoietin receptor agonist like L-Trombopag and Romiplastin.
So level 1, 2, 3, all the things go on one after the other till maybe a kind of a splenectomy. There were some concerns related
With
to
regard
when
to
a patient.
splenectomy, sir, just I would like to again mention here the incidence of splenectomy. The number of patients going on for splenectomy has drastically gone down across the globe because of these fantastic, non-toxic, easily manageable, efficient drugs like thrombopoietin receptor agonists like L-Trombopag, Romiplastin, rituximab, which is anti-CD20 monoclonal antibody.
So there are concerns related to, we deal with many patients who are on drug-eluting stents with dual antiplatelets. They tend to develop the thrombocytopenia with some reasons and unrelated to them. And the cardiac colleagues are concerned about their stents getting thrombosed if the antiplatelets drop. So what is your take in thrombocytopenia with patients needing a dual antiplatelets? How do you take that?
So again, very common, very important question. Thank you so much, Dr. Venkat Ramana, sir, for bringing that question. So platelet count threshold for continuing antiplatelets and anticoagulants is 50,000. So hemostatically safe target platelet count for any thrombocytopenia of any etiology is 30,000. And for continuing antiplatelets and anticoagulants is 50,000. So if these cardiac patients, if these kind of patients who require anticoagulation are having thrombocytopenia, depending upon the etiology of the thrombocytopenia, again, thrombocytopenia is never a diagnosis by itself. You need to work up to trace the cause of thrombocytopenia. If no cause is found, you can consider ITP and start the patients on ITP-directed therapy. Keep the platelet count above 50,000 for continuation of antiplatelets and anticoagulants.
Many situations we come across thrombocytopenia in a hypercoagulable state, as you said, congestion coagulopathy, HIT. All these are considered to be thrombotic. Some of those situations with the decompensated CLD do have thrombocytopenia, but they are hypercoagulable. Your take on that?
So particularly thrombotic microangiopathies like TTP, HUS, HIT. These are the circumstances.
Some of the DICs, hypercoagulable DICs also.
Yeah, yes. So HIT and thrombotic microangiopathy are the circumstances where platelet transfusions are contraindicated unless the patient has active bleeding or you are anticipating any invasive procedure. Coming to DIC, again, treatment of the underlying cause is the most is of paramount importance to correct thrombocytopenia in these patients. Again, if the patient has severe thrombocytopenia, platelet count less than 10,000, or patient has active bleeding, or you are planning any procedure, then you can consider platelet transfusion.
Anticoagulants, yes. Role of anticoagulants in that.
So role of anticoagulants in DIC, because DIC has two, edges. It's a double-edged sword. One hand, you have thrombocytopenia predisposing these patients to internal bleed, serious internal bleed. On the other hand, there is systemic disseminated intravascular coagulation, so leading to multiple end organ dysfunction. So in these cases, patients, depending upon the cause, like DIC in a polytrauma patient, DIC in a gynecological obstetric patients, bleeding is the risk of bleeding is more, so your emphasis on correction of DIC as well as supplementation of these factors for prevention of bleeding. So DIC in the setting of malignancies, DIC in the setting of polytrauma, again, coagulation as well as bleeding, both are more, so you have to trade off the balance between two. Platelet transfusions in DIC is only indicated if the patient has severe thrombocytopenia or patient is actively bleeding. prophylactic platelet transfusions is controversial, and the evidence, literature evidence is very weak for prophylactic.
Most of the times we avoid as long as possible as a prophylactic transfusion. Dr. Sasi, you made some controversial statements regarding you vary from your up-to-date in trigger of platelets. And we are now coming across the platelets number has been dropped drastically from the school times where a neurosurgery or a kind of a very close space surgeries where a smaller amount of bleed can be catastrophic where cutoff of a lakh. Then we had a information earlier with 70,000 for spinal anesthesias or a sentinel axial dropping to 50, dropping to 30. Now we are talking about dropping to 20 when we have a compressible. I think these are all in the view of the risk-benefit ratio of a transfusion, the risk of a bleed in a compressible site where I may not have a catastrophic bleeding. So that's an area of a growth. And what is your take, sir, on these areas where actually Sasi dragged some controversy saying his cutoff is 50, but the up-to-date may say around 20,000 and sometimes it may say 10,000.
Yeah. So there are various guidelines proposing platelet count threshold for various procedures. In general, the American Society of Hematology, International Society of Thrombosis Hemostasis, British Hematology guidelines, these are the common guidelines being implemented and followed by most of the clinicians apart from hematologists. So our threshold for a simple procedure like dental extraction, dental procedure is platelet count of 30,000. Any major surgery, 50,000. Spinal, neuroaxial anesthesia, spinal lumbar puncture is 80,000. And critical organ surgeries like brain surgeries, ophthalmic surgeries, platelet count threshold is 1 lakh. So, of course, there are various variations depending upon which guidelines you follow, but these are the common platelet transfusion thresholds for various.
The most common abused transfusion of platelets is dengue fevers.
Correct.
Across maybe our country. So we have been seeing the different guidelines and we have our own concern. We may sometimes say it's a patient when it starts bleeding, then we may consider thrombocytes transfusion. Sometimes even WHO says you don't need to give, that's a very terminal stage. You may need to give RBCs, that's it at that time. So your take on that, and there are a lot of debates on it saying ki you take some 4 to 6 hours for a donor to get arranged, your platelets to be pulled, it need to be get ready in Indian context, and sometimes the hospital may need to drag it from another unit. So what is your take in a dengue fever?
Thank you so much, sir, for bringing in here another important, burning, pertinent clinical question for all of us practicing medicine. So again, the myth is, dengue fever, high risk of bleeding. That's a myth. Irrespective of the severity of thrombocytopenia, the dengue fever patients, the terminal catastrophic event or the concern in these patients is dengue shock syndrome because of increased capillary permeability. Of course, thrombocytopenia can be a progressive thrombocytopenia can be a surrogate marker of these patients sipping into dengue shock syndrome. But thrombocytopenia per se doesn't lead to any mortality in dengue fever patients. And as like any other platelet transfusion indications, the absolute indication of platelet transfusion in dengue fever patients is when they have a platelet count less than 10,000 or when they are having active ongoing bleeding or when you are planning any procedure like central line or any procedure in these patients where you need to maintain the platelet cutoffs for those procedures. Barring this, prophylactic platelet count transfusions for patients with platelet count above 10,000 is the evidence is weak, controversial. That is very, very important. And most important is dengue. The most catastrophic event in dengue fever or in the dengue shock syndrome is the evidence of dengue shock as established by the clinical as well as lab parameters.
So isolated thrombocytopenia causing bleeding leading to death is a rare phenomenon in dengue patients, whereas probably that leading to DIC causing extensive bleed leading to death are more commonly seen and which probably are in the last terminal of the tunnel. So
I would like to add
very-
another important point for many physicians on this August virtual platform. So another parameter which which is a kind of a reflection of ongoing marrow compensation for severe thrombocytopenia and possible platelet recovery in a short future time is mean platelet volume as well as platelet distribution width. So these parameters can be IPF, immature platelet fraction. These parameters, the high IPF suggests that the marrow is producing platelets appropriately and platelet recovery is going to be evident soon. So in those patients, irrespective of severe thrombocytopenia, you can still keep a watchful waiting because platelet count is going to recover soon in the future.
Yes, sir. I think we had an extensive discussion, and thanks to both Dr. Shashidhar in bringing those cases and interacting. And thank you, Ganesh sir, for elaborating on all those cases. And I think we should thank all the participants who were hanging around for last 1.5 hours. It was one of the longest sessions we had. And I thank both of you, and I conclude the session. Thank you both, sir.
Thank you, sir. And again, before we conclude, thank you to all the eminent panelists on behalf of Yashoda Group of Hospitals for sparing time amidst your busy, hectic schedule, and that too stretched long hours on a weekday. So thank you, Venkat Ramana sir, Dr. Shashidhar, for such elaborate discussion. And most of all, thank you to the all eminent panelists for sparing time. And look forward to many such academic discussions in future. So goodbye, take care, stay safe.
Thank you, Sasi.
Thank you.